So just about time now. Thank you very, very much, everyone, for joining us. This is the Academy's AONM's second roundtable with this wonderful group. Thank you very, very much, Professor Leona Gilbert, joining us from Finland, and Dr. Sarah Myhill, joining us from the depths of Wales, and Armin Schwarzbach and Dr. Zhaneta joining us from Augsburg. So we'll be going through a few cases in a minute, but first of all, we've got an update from Leona. So Leona, perhaps you'd like to share your slides and just let us into these interesting details.
Yes, and thank you for showing up, guys, and greetings from Winter Wonderland, because it's really snowing here. But I wanted to mention, if I can, last roundtables, we had a discussion about me encouraging clinicians and scientists and collaborators alike to actually establish patient databases so that we could mine it and publish. And I gave an example of the first publication that we had with this Irish consortium from Jack Lambert's group in Dublin. And this was a really nice start with his database, but this is another research paper that we're going to submit tomorrow. And what we did is we had a goal of actually scrutinizing his patients that he saw at the Mater University Hospital. And we looked at clinical biomarkers in not very specific biomarkers, but we looked at general biomarkers, immune markers, general clinical markers, and we wanted to see if we could actually describe the patients that he was seeing. And this is really an example of how once a database, patient database is established, how easy it is for us to go and start publishing on his patients or the consortium patients. And we can pick out different kind of special cases and case studies or series cases and publish that as well. So I encourage you as well to go and establish databases, or if you need help with that, come talk to us. We can help you establish databases and we can help you start publishing on your patients. And I just wanted to go over actually what we did in this paper that we're going to submit tomorrow. So we took 110 patients that are suffering from tick-borne infections. And particularly, we looked at, of course, the serology, but we looked at basic immunological biomarkers, including, CD markers. And we also took a particular attention to the negative serology patients or the negative seroconversion patients. But we started with originally 110 of these individuals that have a positive serology to tick-borne infections, okay? And these individuals have been suffering a long time and on an average saw maybe 6 doctors before they came to the Mater University Hospital to seek help. And we screened them with just basic clinical immune markers. And what we saw is low CD3 percentage and low CD positive cell counts. We also saw low CD8 suppressor cell counts, low CD4 and CD4 plus percentage counts in approximately 20% of these patients. But what was interesting was that in the negative seroconversion group, subgroup, okay, they didn't have serology to any of the tick-borne infection microbes, but what we did see, they still have really low CD3 percentages and CD plus cell counts. And they also had a CD8 plus suppressor cell count and at about approximately the same amount as those seropositive patients. And the take-home message really is that these individuals, there's a large proportion of these chronic patients that have really a compromised immune system because they have low lymphocyte counts, okay? And the negative patients in serology doesn't mean that they're negative, truly negative. They just most likely have a very low immune system because they don't have enough lymphocytes to combat, the infection. But what's interesting, we looked at other markers, CD57, natural killer marker, okay, and also CD19 markers. And CD57, natural killer, of course, is also a marker for immune suppression. And interesting, those people that actually paid for this test, so we only have 37 patients. However, again, we saw a high proportion, up to 60% of these individuals are suffering from a low CD57. And again, this is hinting that this is a really good marker to look at immune suppression. And then we looked, of course, the CD19 percentage. These are markers for B cells. And we looked at 101 patients, and there's a high majority of these individuals, like 40% and 15% of these people are suffering from low CD19 percentages and CD19 plus counts. And basically, the take-home message is this. The database that you established, we could actually mine and look at these basic biochemistry markers. These weren't only the markers that we looked for. We looked at biochemistry markers as well. But these were the zero, so baseline counts we took, but after treatment, okay, and our first publication that I mentioned in the last roundtable discussion, I displayed a combination of long-term antibiotics, okay, treatment that was used at Mater University hospitals to manage these patients, and 75% of those patients saw a diminishing in symptoms, severity of symptoms, okay, and these individuals, we generally saw improvements of CD3 markers, CD4 markers, okay, but we didn't really see improvements in the CD8 suppressor cell counts. But interesting enough, other markers like transferrin, and we'll go into this maybe in the next roundtable of the significance of transferrin, but we definitely saw deficient transferrin even still in these individuals. Now, the take-home message, really, why I wanted to present this here is that we could use basic blood chemistry, basic blood counts, okay, that's offered at many laboratories, even Armin's lab, and we could really mine the data and see if it can actually define who your patients are coming to your private practice or your practice. And that's the whole point, to really encourage you guys to please be in contact with us so we can help you establish a patient database and we can get started on publishing, your patients that you see in your practice. But then the last slide I wanted to mention is, because I'm always promoting, publishing and always encouraging, expanding the field of Borrelia research, is this Borrelia Methods and Protocol from Springer Protocols is a book that is a collaborative effort with many different scientists, including scientists and clinicians from even Armin's lab, okay? We have come together with 18 chapters of different protocols, and we put it in this book, and this book is going to be published at the beginning of January. And I believe that we'll definitely have a seminar on this to go over some of the novel, innovative methods that are encompassed in this book. The last time this book was published was 6 years ago, so it's about time that we get actually up-to-date methods, research methods. And the goal of this book was really to provide in vitro, in vivo, de novo, in situ, okay, protocols that even medical students, master students, PhDs, postdocs, clinicians can follow, so that they could actually expand the research concerning Borrelia burgdorferi. And then the last two pictures that I have on this slide is actually journals that we are going to be co-editors of in special issues. So Frontiers in Medicine and also Frontiers in Microbiology is a platform, and a safe platform, and with like-minded individuals, that is a place that you could go and submit your articles for peer review, okay? And hopefully expand again your publishing experience, and also to really tell about your clinics and your patients and what you're seeing, the novelty that you're seeing, and what is working, what isn't working, and actually for the benefit of expanding the research in our area. So Frontiers in Medicine is going to be focused on One Health approach, and Frontiers in Microbiology are going to focus on innovative therapies as well as diagnostics, but also case studies and case cohort series case studies are also going to be streamlined to a sister journal as well in the Frontiers. So starting of next year, we'll have an opportunity to have a safe place that we could submit our research publications or case studies, series studies to. So I encourage you to be in contact with us so that we could, provide it more information on where to submit and how to submit. So, yeah,
maybe you could pop the email to which people could get in contact with.
I'll put it in chat
if they are interested in submitting articles.
Yeah, I will put it in chat. And if you have any questions in regards to anything, absolutely, please contact us. So no issues with that.
Thank you. And we'll let everybody know when the book is available. We'll obviously send out a special e-blast about that.
First week in January.
Brilliant. Yeah, thank you. Thank you so much, Leona. Fantastic information. And Dr. Sarah Myhill has a little bit of information on a very exciting event that took place a couple of weeks ago.
Well, this was by invitation of Andrew Bridgend, who, as you know, has developed a reputation for telling the truth in Parliament. And he wanted to have a meeting to look at how Lyme disease is recognised, diagnosed and treated in this country. And I came down because I had been in touch with a friend of mine who had a case of, he'd been on holiday in East Coast America in Vermont. He picked up tick bites when he was out there. He developed a debilitating illness, and it took nearly 3 months for that to be properly diagnosed in this country, even though he and his wife continually said, could this be Lyme? Could this be Lyme? Could this be Lyme? And the only thing that prompted the hospital to test for it was having had endless investigations, endless tests, having been as an inpatient in hospital for 2 months with severe debilitating pain, losing 2 or 3 stone in weight and really being completely bedbound. Eventually a lumbar puncture was done. A white cell count in lumbar puncture should be about 5 white cells, and his was 55, clearly showing he had a major inflammatory condition going on in the brain. And when they sent bloods down to Porton Down, eventually, they demonstrated high antibody titers, indicating he had neuroborreliosis. And he was treated for 3 weeks with intravenous antibiotics, ceftriaxone, 2 grams twice daily. And during this time, he has improved enormously. He had the most extraordinary pain, which he describes as like a carapace. So like if you had a turtle's shell on your back, over your shoulders, back and hips, it was just... that was the distribution of his pain, and it was so severe. The only place he could be comfortable was in a bath, being sustained by held up by water. Any other position was uncomfortable, and all that happened in hospital was he was giving endless painkillers. He was on opiates and every painkiller you can imagine, and that really didn't make one jot of difference to him. Now he's being correctly treated and he is starting to recover. And this flags up, the issue in this country, which is that GPs should have access to good testing for Lyme disease. And if we can't provide the facilities in this country, then we need to have a facility where we can get bloods to Armin laboratories. And because, of course, the testing varies depending at what stage of the infection you've got. And at different stages, you might need a PCR, you might need antibody tests, and you might need cell-mediated reactions like ELISpot. And in this country, all we have is antibody testing, which, of course, is bound to miss cases, and is not easily and quickly available. So the whole idea of this meeting in the House of Commons was to flag up the need for proper awareness amongst clinicians and access to good tests so that people can be diagnosed early and treated early. Because, of course, the earlier and the sooner you can treat, the better the prognosis, the better you're going to be. And the key to remember about Lyme disease is that it's a spirochete. Now, when I was a medical student in the 1970s, the disease that was the great mimic was another spirochete, and that was syphilis. Syphilis could present with almost any clinical picture you care to name, and so it is with Lyme disease. It can present with almost any clinical picture you care to name, from a dementia to Parkinson's disease to arthritic conditions to autoimmune conditions, etc. So it always has to be part of your differential diagnosis. And to have half a chance of picking it up, we need good tests in this country. And in the absence of that, it's got to be Armin Laboratories.
Thank you so much, Sarah. What a moving case. My goodness. Wow. Armin, I believe you were there as well?
Yes, I had the honor to do the first talk, and it was a fascinating group also of complementary therapists. And Andrew, the Member of Parliament, was very interested also in complementary therapies. He didn't use, he asked me, what do you think is the reason behind that, why we don't use complementary therapies? And I said, okay, you could kill me outside, but I think it's a word with a big PH, big pharma behind that. So it's a lot of money and conflicts of interests. And he agreed. So there seem to be politicians who are open-minded also to break a little this circle, which is not good for the patients, because patients suffering from painkillers, corticosteroids. We all discussed that with him, and I think he was really, really open-minded. The question is if he's strong enough against the lobbyism, which is for sure also in the British Parliament or members of parliaments there. But it was the first action. I had a really good feeling, and I think, Sarah, you could confirm that.
Absolutely, absolutely. I mean, the point about Lyme disease is there are some people that focus on the microbes, and there are some people that focus on complementary therapies, and some people that focus on the immune system. And the fact is we have to do it all, because if you've got one major infection in the body, then that is there because we are immune compromised very often. And being immune compromised, you're then going to get other infections coming along. And, one of the features we know of long COVID is that it unmasks other underlying infections, such as Epstein-Barr virus, which hitherto the immune system was keeping in check, it was keeping in control. And the same is true of Lyme. Once you've got Lyme in, your immune system is compromised necessarily, simply because it's trying to deal with that infection that's there already. And therefore, it's much more likely you're going to get other co-infections in there, whether it be mycoplasma, Epstein-Barr, other herpes viruses, or whatever. So we're seeing people with complex infections, and it's going to be a multi-system approach that deals with those. Now, I don't pretend to be expert in treating Lyme or Epstein-Barr or mycoplasma or whatever. But what I do know is if you can put the immune system in the best possible condition then to deal with that infection, then any interventions that might be herbal, they might be prescription drugs or whatever that help to reduce the infectious load, means that the immune system is going to be in a much better position to deal with the remaining microbes, to focus its intention on the microbe. One of the lovely analogies I like is that mast cells are angry immune cells. And if you've got angry immune cells, then they tend to fire off all over the place with allergy and autoimmunity and useless inflammation. So we want our immune cells to be focused on the job in hand, i.e. focused on that particular microbe, and not, firing off, in a random fashion with useless inflammations. And we know that allergies are associated with these conditions. We know that MCAS, mast cell activation syndrome, is associated with these problems. We know autoimmunity is. So it's all about helping the immune system to deal effectively and appropriately with the infectious load that the immune system is tackling, and then use antimicrobials from the herbal world, from the fungal world, from the drug world to try to reduce the infectious load. So that's how I see as the overall strategy. And what it means is that individual people will probably end up with tailored individual regimes to help them deal with them. But the overall strategy is the same. Look after the immune system, reduce unnecessary inflammation, and try and target specific infections with specific antimicrobials.
That's a wonderful segue to our first case, Sarah. Exactly. They're all very complex today. I'll just describe a few details of it. It's someone who unfortunately suffered a dengue infection in Haiti, and then chikungunya virus in India. And she initially presented with fever, lymphadenopathy, and joint pain, fatigue. And she was treated at a big London hospital. But then her post-chikungunya arthralgia continued with sleep disturbance, central sensitization, positive ANA, and Raynaud's disease. And to cut it short, because there is a lot of detail here, her current symptoms include severe fatigue, digestive disturbance, insomnia, joint pains, and anxiety. And I'll just read through the infections that she has come up positive with at ArminLabs. And the question is how to, or at least a few tips on where to put the emphasis, whether viral or bacterial, and also a few initial starters on exactly those 3 I's that you've just mentioned, Sarah. So her Borrelia was a 4, a 1, and a 2. You know what that means, yeah?
Yep, Ellie spot, yeah.
On the Ellie spot, her Ehrlichia anaplasma was a 5. So that's unusual to come up with that in this country and so high. Her Babesia was a 3. Her Mycoplasma was a positive IgG. Her Rickettsia was a 2. And she had positive IgM on both the round bodies and the normal form, as it were, of Borrelia burgdorferi on her tickplex basic. So that's what was tested for. No viruses, in fact, were tested there. But I'd like to ask you, throw it open to any of you. She is on pregabalin and citalopram, and obviously a number of supplements. But any comments there on that difficult case?
Well, I always, whenever you get difficult cases like this, what I start off trying to do is tease out from the symptoms the mechanisms that are going wrong. And of course, if anybody has physical fatigue or mental fatigue, that's symptomatic of poor energy delivery mechanisms. And so, I always would start with poor energy delivery. And the analogy that you all know that I love to use is the car analogy. And for good energy delivery, you've got to have the right fuel in the tank. That's all about diet and gut function. You've got to have good mitochondrial function, because obviously mitochondria is central to improving energy delivery mechanisms, and then good thyroid and adrenal function. So I'd always start there. And then because she's obviously got a multiplicity of infections, and there may be other things that have not been tested for, I then try to put in place general interventions to reduce the total infectious load. And, vitamin C to bowel tolerance is a great start. Iodine, as you all know, it's one of my favorite multitasking tools. That's a great start. And then there are lots of other herbs that have broad spectrum antimicrobial activity. And you can maybe focus those herbs with particular infections, but I tend to use basic things like Chinese skullcap, Japanese knotweed, rhodiola. These have all antimicrobial activity. But what I'm using at the moment, which has broad activity against a range of viruses, bacteria, and fungi.
Sarah, could you repeat that? After what I'm using at the moment, we lost you for about half a minute.
Okay. So what I'm using at the moment to reduce the total infectious load is a combination of therapies, all of which in isolation are antimicrobial, but in combination work even better. And that's methylene blue, which has broad antimicrobial actions against viruses, bacteria, and fungi. DMSO, which again works probably by breaking down biofilm and also improving membrane function, which has huge impacts for mitochondrial function and circulation. And then activate that with photodynamic therapy. So that's red light and near infrared light. Now, these are all very inexpensive interventions that most people can afford, and gradually increase that to reduce the total load. And I've had some very useful successes in people with whom I've previously struggled and are now making, gradual progress in the right direction. So that's how I start, and then maybe add in specific antivirals or antibiotics or whatever. But I always start with that basic package.
Oh, thank you. Armin, I know you mentioned earlier regarding chikungunya that you've had a few patients with it. It's an incredibly difficult infection to cope with, isn't it? And it can last for years, can't it, the effects?
Yes, that's a key question. Is it like the spike protein circulating with the antigenity? Is it the rest of that in the macrophages or on the tissue? So from the teaching books, from the microbiology books, cannot get chronic, okay? So we discussed that it's more reactive, reactive arthritis. If you have Yersinia, it's reactive. So why reactive? What we didn't respect there in the discussion, it's LFA1 was positive, you mentioned, in the Borrelia list report, and yes. LFA1 is autoimmune. Borrelia is doing autoimmunity, okay? So Borrelia IgM active. So Th2 dysbalance to Th1, a lot of overproduction of Th2. So you need to support Th1, although she's still reacting on the ilis spot. So she shows some cellular immune reactions, but she's overstimulated in the antibodies for sure by chikungunya, by this double infection. And by this, I'm pretty sure there are a lot of infections reactivated. That doesn't mean that she all got from one vector bite in where she got this infection with chikungunya. Maybe she had it in the body, and then she lost the control over it, and then we name it opportunistic infections. And this is for sure what Sarah mentioned, the immune system plays a very, very important role. And then I want to come back, Sarah, some ideas about the gut, because I'm pretty sure these patients all have gut immunity problems, and we need to support the gut somehow, or?
Absolutely.
And what would you do?
Well, I mean, we have to ask whereabouts in the gut is the problem arising. And to know whereabouts in the gut the problem is arising, we have to look at what constitutes normal gut function. So the upper gut, the first 22 odd feet of gut, so the esophagus, stomach, jejunum, small intestine, should be near sterile. Should be near sterile for the purposes of digesting protein and fat. Now, the problem with people eating high carbohydrate diets is they overwhelm the ability of the upper gut to be sterile, and you have a fermenting upper gut. And those microbes in the upper gut that are fermenting are not evolutionary correct microbes. They're relatively recent things like the Streptococcus, Staphylococci, Klebsiella, some E. coli's, which really shouldn't be there. And those, we're taught at medical school, yes, the gut is full of microbes and there they remain, but we now know that's not true. Those microbes very easily get into the bloodstream. Now, these are not familiar, evolutionary correct microbes. It switches the immune system into a state of inflammation wherever those microbes happen to end up. So we know, for example, that rheumatoid arthritis is allergy to microbes from the upper fermenting gut and probably allergy to Proteus mirabilis. We know that ankylosing spondylitis is molecular mimicry, is allergy to Klebsiella in the gut. We know that psoriasis has a fungal driver. So psoriatic arthritis may be driven by allergy to fungi in the upper gut. So the first thing we have to do is sort out the fermenting upper gut. And we do that with a low ketogenic diet and vitamin C and iodine. And then we have to look at the large bowel, where the microbiome, the last 5 foot of gut, that's where the microbiome is. And that's where we have kilograms of microbes. Now, we've had kilograms of microbes in the large bowel for hundreds of thousands of years. The immune system has learned to recognize them, understand they're friendly, and so they don't, if they do escape into the bloodstream, they don't upset the immune system, they don't switch it on. And so we have to try and look after our microbiome as best as we can. Now, we don't know much about the microbiome, but what we do know is that the more diverse it is, then the healthier is that person. And you can maintain a good, diverse microbiome by eating a diverse diet. And so I ask my patients to aim to consume 30 different foods a week, at least. And of course, as as you progress through the year, we're going to get even more different foods, because our diet should change throughout the year depending on the fruits and the vegetables and whatever is in season at the time. And so it's a very blunt, it's a very kind of all-encompassing approach to treating the gut, but that is the starting point. One day maybe fecal bacteria therapy will be much more available, and we know that's a very good way of impacting on the microbiome. But of course, fecal bacteria therapy has a major yuck factor attached to it, and
we've got the crapsules, haven't we?
It's correct. That's the treatment that's in the pipeline, which I think will be very useful and much more easy to access. And those are the crapsules, as they're called. So these are microbes from a healthy microbiome that have been encapsulated in a capsule that keeps oxygen out, and these microbes are freeze-dried, so they survive. And I think that's going to be a very useful way forward to increase the diversity of the microbiome, because it's the microbiome that is in programming our immune system and allowing our immune system to react correctly to the microbes that it should ignore because they're safe, and then attack the microbes that are not safe, perhaps. So that's the overall strategy, but we still have much work to do on the nitty-gritty of how we can actually make that happen for individuals.
Thank you so much, Sarah. Well, that was lots and lots.
Zhaneta wants to say something to the hormones.
It's very important, the hormones. You check the hormones in the blood test.
Absolutely.
And melatonin, serotonin.
Melatonin, serotonin.
But it's, by infection, it's very, very important.
Serotonin
the melatonin
is
going down. And tryptophan.
So
L-tryptophan.
Tryptophan.
but many of those neurotransmitters derive from
cortisol and parathormone.
Cortisol,
parathormone.
This is an idea, just maybe to check the hormones for this patient if they were not done, because what is now happening, the psychiatric doctors, they prescribe these uptake inhibitors, like this escitalopram, and the patients get dependent on that. And the serotonin is low. Okay, we can measure that. Melatonin is low. But it's a masquerade. You work on the serotonin deficiency, which is caused from infections or the gut immunity or something like that. So I think this we need to respect that, the hormonal axis. Is this what we mean from our side?
Super, thank you. A lot of that will be relevant for many of the cases. Leona, did you want to say something?
Actually, we have questions in the chat, but I would encourage everybody to put the questions in the Q&A slot. And then we have somebody that has their hand up that wanted to talk, if we have a moment. Or do you want to take this at the end?
Came in previously that I think we don't normally do that with the hands up. I know you said, Leona, that somebody had asked what Lyme doctor is there available in London. We don't actually ever give out specific names, but we do have a list of that would appear as a sort of testing lab, as though we were favoritizing specific therapists, and we're just not allowed to do that. But we do have a list of practitioners that you can access. They're all practitioners who are familiar with using our tests, and do please write to info@aonm.org, and then they will be very happy to give you that list, both of practitioners here in the UK, and Armin has given us a list of practitioners from Europe. So, it doesn't matter where they are really, unless you absolutely need a physical examination. You can correspond with or have a consultation by Zoom. So the next case we have here is a female, 56 years old. She had a tonsillectomy as a child, and the question will be which tests she should do, because theoretically there's a huge, well, not even theoretically, there is a huge number of tests she could do. I do have the checklist available if I have time to show that, but for budgetary reasons, it's not possible to do all of them. So tonsillectomy as a child, possible glandular fever in her teens, blood poisoning from a bacteria from a jellyfish in her teens, issues with the bone structure in her feet resulted in removal of some bone from the toes on each foot. A very, very traumatic event in 1994, where she actually witnessed the death of her sister. We shouldn't underplay psychological issues either. They also can turn physiological. And then 9 amalgams removed, hopefully safely, in 2008. Arthroscopy on her shoulder, resulting in nausea and exhaustion. Overall, she's just, got a lot of different issues. She did in 2016 get diagnosed with CFS, chronic fatigue syndrome, but we know that that's often a basket of many different symptoms. So I'll just show you, if I may, and if I can access it sort of elegantly, I'll show you her checklist, which is here. Some of you may be familiar with this. This is the co-infection checklist. Obviously, there's a possibility of Lyme disease, which we've just been discussing too, because she did recuperate in Bali. She was sort of given that as a present, I think, by her parents, but she did catch an unknown infection 2 days before leaving. And of course, I do know of people who've gone to Bali to recuperate and picked up chikungunya there as well. Yeah. But here we are with these, obviously, tests coming up high. These are the enteroviruses, Coxsackie echo, the herpes viruses there. Maybe, Armin, I could pass this on to you to start with the background I've given you and the checklist.
Yeah, this is a very typical story we see every day. And the gut plays a role again, to Sarah coming back later. The Coxsackie and the echovirus, typical childhood illnesses in infecting the tonsils, and then you remove them, and then you get the problems. So you cannot remove a virus from your body because it's all over the body. The same with EBV, CMV, opportunistic reactivation. These are all mitochondriopathy viruses. They all do mitochondriopathy. It's not just Lyme disease. They use your ATP, your intracellular, so they get really tired. All of these patients. That's very typical because they suck away. If you had corona, you know what I'm talking about, or influenza. Also, Bartonella came in this very interestingly. Bartonella is cat. I would ask for cat scratches. Okay, foreign countries, could be the contact to cats, maybe in childhood, I don't know. This is a very old story, it started during childhood and now it's a reactivation, maybe stressing factors again. But very important, also mycoplasma, chlamydia. This is the leading constellation in the world. Also long COVID, post-COVID, we see always these people. Not everybody has it active, but let me say 3, 4, 5 infections always active in this patient. So in the end, it doesn't matter if you have 5 viruses, you treat the viruses, but you know to need the direction. If you don't know it's virus active, that's pretty sure Coxsackie echovirus. So ask for herp angina, the blisters in the mouth coming back sometimes. The tooth surgeries are not so good for the immune system. This could reactivate after surgeries. You get a lot of reactivations of these opportunistic viruses, opportunistic pathogens. The story is more than Lyme disease, maybe to say that.
Mm-hmm. So you would say perhaps to focus specifically, if not many tests can be done on the enteroviruses?
Yeah, the gut plays a role.
And the herpes viruses?
Yeah,
because they came up tops.
Yes,
okay.
And the Bartonella, maybe with the cats, you could ask it.
Yeah.
Anamnestic question.
Yeah. Okay, well, if you don't mind, we'll just go on quickly because we have so many cases. Here's one where the person who wrote in, it's actually her birthday tomorrow. So let's answer this one as well. This comes from France. She says 18 days ago, she collapsed with a very sore throat, lots of congestion and extreme tiredness, so much that she had to spend 18 hours a day in bed. The local community, very rooted in medicinals, came with Artemisia annua. So she took that 3 times a day. She's been following Dr. Myhill's remedies with lots of ascorbic acid, vitamin D, selenium. Since then, her cough is better, sore throat is gone, still some congestion, but the brain fog and tiredness are there, and she cannot go far without sitting down. She's going to be 83 tomorrow.
Bless her.
She just wonders what else she can do. She's finding the fatigue alarming and a real slippery slope.
Well,
So,
she's got she'd had an acute upper respiratory tract infection with almost certainly viral, probably COVID. And we don't get over that in a few days. It does take a few weeks sometimes to recover. And you just plug on with the vitamin C. One of my favorite remedies is iodine. I know I'm always banging on about it, but this works so brilliantly well for any respiratory infection. And for those that are not familiar with it, this is a salt pipe, which is just a plastic tube with holes in the bottom and a nozzle at the top, filled up with sea salt. And you put a couple of drops of Lugol's iodine in the mouthpiece. Iodine is volatile, so a couple of drops in there, give it a shake and sniff it. So sniff it up through the nose. Now, the point here is that iodine contact kills all microbes. There is no microbe that is resistant to iodine. And I now have 5 patients with bronchiectasis, which is chronic lung infection. And by dint of doing a keto diet, taking vitamin C and sniffing iodine, their need for antibiotics has dropped to 0. So what this lovely lady needs to do is to keep the infectious load down, continue to take the vitamin C, continue to sniff iodine, and give the immune system a chance to get ahead of the game. And it's really important during this time, good old-fashioned nursing care. Rest up, keep warm, don't eat lots of sugars and carbohydrates, don't take symptom-suppressing medication like paracetamol and aspirin, which stop the immune system from fighting. And there's no reason why she shouldn't make a full recovery, but give it time.
Sarah, one question in the Q&A is what the concentration of the Lugol's is. I'm not sure there whether she means how much iodine is in it or how much you should give.
That's 15%, but you can use 12%, 8%, whatever. But the key is if you can smell it, then you have a therapeutic dose. Iodine kills all microbes at 10 parts per million. And if you can smell the iodine, which I can from sniffing that, then you've got a therapeutic dose. And what that does is it keeps the numbers of microbe down. And it doesn't matter what the microbe is, whether it's viral or fungal or a bacterial, it keeps the numbers down. And then the immune system can deal with the rest. The immune system can mop up what's left. But don't feed those infections with sugar and carbohydrates. All microbes love sugars and carbohydrates. They cannot survive on fat. They cannot survive on ketones. So feed the body with a keto diet, a low carbohydrate diet. I hate seeing people in hospital beds surrounded by fruit, but surrounded by grapes and melons. It's the worst thing you can do for them. It's absolutely shocking. So a good keto, and of course, let's ask what wild animals do when they get an infection. What wild animals do is they creep down a hole, they shut themselves down, they keep warm, and they fast. They don't eat anything at all. They rest up completely so the immune system has all the energy that it needs to deal with that infection. And when they've got rid of it, they'll get out and get on with their lives. So fasting is also a very good treatment for people with any acute infection. But say if you feel you can't manage a fast, whatever you do, don't have sugars and carbohydrates, which simply feed the infection. And these very simple naturopathic techniques have been known about for hundreds of years and written about and documented as being safe and effective. So don't look for something esoteric. Let's use the old-fashioned stuff that we know works really well and is cheap and available to all.
Oh, thank you.
Gillian,
go ahead, Armin, sorry. Yeah.
Gillian, 2 points. I have thought about chlamydia and mycoplasma, okay? So that would fit to Sarah, which is very, very common reactivated also in long COVID, post-COVID patients. You do the IgA, then you know. They have some cough, and Leona, you're the biofilm expert. I think it makes really sense to drink a lot, 3 liters water without gas, no sugars. Okay. And what about biofilms? Chlamydia, mycoplasma doing biofilms, spit them out, there's slime coming. What should we do?
With the biofilms.
Yes.
Yeah, there's many things. I mean, and of course, I'm not a clinician, so I can't give therapies, but Sarah can comment on it. But there's lots of research to suggest different compounds that could help with the biofilms. So yeah, Sarah, you should give this advice.
Oh, I'm not sure. That's right. But again, iodine is, because it's so volatile, it goes straight through. I would expect it to go straight through biofilm. Now, I'm not sure I can point to a study that demonstrates that that is the case, but it's certainly biologically plausible. It's such a good antiseptic. DMSO is another very good compound to use. It's a universal solvent. Anything and everything dissolves in DMSO, and it gets through the skin very easily. And that too will break down biofilm. Some clinicians are keen on using enzymes like serrapeptidase or nattokinase to break down biofilm. Again, it's biologically plausible. I don't know if it actually works, but these cheap, simple remedies used in combination, we know they get clinical results.
And I can say in vitro studies, hydrogen peroxide, a very, very low percentage of hydrogen peroxide. And I know actually a case study, this gentleman swore by it, that whenever he felt a little tickle in respiratory, like influenza or cold, he would inhale, hydrogen peroxide, not 30%, but it was like 0.5% hydrogen peroxide. But we do have data to support that hydrogen peroxide works in vitro to break up the biofilm. So
hypochlorous acid as well, HOCl.
Yeah, exactly.
What about methylene blue? We discussed in ILATS Boston methylene blue.
Correct.
Okay.
And methylene blue, I don't know if you've ever tried the stuff. It's extraordinary stuff. It stains everything blue. And of course, we know that the pathologists use methylene blue, don't they, to stain the slides that they're looking at. So we know it gets into cells and stains mitochondria. So and mitochondria are essentially a tamed form of bacteria, aren't they? From the evolutionary perspective, mitochondria are bacteria. So we know from simple pathology that methylene blue is going to penetrate mitochondria for good reasons, and bacteria maybe to kill them. So yes, methylene blue is such a useful tool. In fact, I noticed in the question answer book, somebody says, oh, I can't, as a holistic practitioner, I cannot prescribe methylene blue. I don't prescribe methylene blue either. What I do is I tell my patients about the options, and then they can go and make their own choices, and they can purchase methylene blue. And that's the joy of naturopathic medicine. We're not prescribing, we're not directing, we're saying, these are the choices. Now you go and make your mind up. You go and choose to use vitamin C or iodine or methylene blue or whatever. And that gets around what I call the blame game. Because if you try to micromanage your patients and say, oh, you must eat this, or you can eat that, or take this, or take that, then they keep coming back at you to be micromanaged. And I find a really important part of being a clinician is to give my patients the information and the options and let them make the choices. So they are really taking control of their own disease rather than being reliant on me to tell them what to do from day to day.
Yeah, we have hugely informed patients nowadays. It's absolutely true. Yeah. Is it okay? Yeah, go ahead, Leona. Sorry.
Because I'm always the scientist trying to say, okay, provide the evidence. I hope that though when you provide these options, I'm sure it's evidence-based at some extent, and then of course anecdotally based, but that's where I would say that we need more studies on a lot of these compounds that you have mentioned. And it's very easy to try to provide these studies. Like somebody said that, this lauracinin, monolaurin, it's coconut oil. There's conflicting studies on that, but a lot of people have had success with it. So I think that with more research and more publishing on your experiences, I think that you could actually, provide this evidence-based approach to this advice that you're giving the patients. So I just want to point that out.
You're absolutely right.
Can I go on to the next case then? I'll try and summarize it as best I can. This is a patient who's been given a diagnosis of a functional neurological disorder, and that is a bit of a nasty one in the UK because it used to be called somatic disorder. In other words, you're making it up. So we need to, jump onto this one quickly, I think. This came on after a trip to Spain last year. She didn't experience any bug or tick bites that she knows of or any illness while away. 4 to 5 days after returning, she experienced burning sensations in her face and the onset of fatigue, numbness in her face, and then lost the ability to walk. medical tests have not picked up anything except for a small need for B12, which she's getting. So she struggles to walk, and she does the best she can. She gets extremely tired, has brain fog. Her legs feel tingly. She gets pain down her right leg in the front lower shin. She does have a history of poor immunity and viruses from the past. So I'll just again briefly show her checklist, and also mention that she is currently a strict vegetarian and has been for 30 years, but did at times eat fish. So I'll share her checklist again, because she is also someone who can't afford to do too many tests, but she has filled out both. Oh dear, I'm sorry, I seem to have lost it now. I'll leave it like this. She's filled out both her post-COVID checklist and the co-infection checklist. Not a Lyme one, though you may well say, well, Lyme should be done too. But you can see that overall Coxsackie as an enterovirus is coming up quite high, well, very high actually. Mycoplasma, chlamydia pneumoniae is the number one on both. And Bartonella, interestingly, on the co-infection checklist, we don't have those infections on the other one because it's post-COVID. And so, Armin, should I leave this up, do you think, or have you pretty much sort of absorbed this? And should we go back to... Zhaneta, yes.
Yeah. This is typical. I have in my clinic every day the same situation from patient.
Okay.
And it is number one is Coxsackie virus, number two is cytomegalovirus virus and herpes virus 1 and 2, and chlamydia toxoplasma.
Okay.
But it's very, very important, the treatment, and it's very individual from patient, and it's very, very important. And one test for the a stool test in the gut.
Mm-hmm.
And in treatment, it's for me very important high doses vitamin T and L-leucine and
what was that one? Was that lysine?
L-lysine combination with zinc and magnesium, and very important, and Artemisia infusion and curcuma every day, 3 grams every day, and in the 2 week 8 grams. It's very important. It's anti-inflammatory.
So sorry, do you think then that she could begin with that kind of treatment without even doing testing?
The 4 is testing for the gut and the blood test, and the treatment is very individual, but is in the for the immune system. The treatment is very important. Vitamin T, zinc, L-lysine, magnesium, artesunate, and for the gut is very, very important. For the leaky gut.
Yeah, I understand totally. Armin, is your feeling
that is number one?
Gillian, with this Spain, when I hear Spain, I think about CMV, cytomegalovirus.
Yes.
Spain really? Yeah, I was thinking about the air and the aeroplanes, flying backwards and forwards. We have a lot of patients coming down with terrible conditions after flying. Yeah.
Yeah, maybe, but Spain, if you travel to Spain, the high risk is for this viruses because it's so massively spreading a very, I think, aggressive subspecies of the cytomegalovirus. And this also, it makes heavy metal problems. So with the toxins, toxicity, there's a combination with it, and the gut for sure.
And the gut.
And the immune system, but the immune system is a general thing for all of these infections. But for Spain, I would check her for Coxsackie virus, for sure, and this cytomegalovirus, if she wants to spare the money, This is the 2 must-do tests for Spain.
Oh, okay, totally understand. Could I just, because we've mentioned flights and difficulties with possible the air recirculation in aeroplanes, could I mention one more case? Much of what you have said all applies, but this is a patient. I'll just show you his foot. And again, I'll see if I can share it. without making too much of a mess of things. Let me try and share this one here. So he has had very, very serious problems after traveling to the sort of Middle East, Dubai, Saudi Arabia, a lot of air travel. He felt pain on the bottom of his foot and thought it was plantar fasciitis, flew to London from Kuwait City, and the left foot became so extremely painful to walk that he had to, become immobile. Went to A&E because it had all become so painful, was examined, and overall the diagnosis, I think, as far as they could give, was searching here, PUO, pyrexia of unknown origin, is what they've landed up with, which isn't particularly helpful. So the question really is whether you have any further ideas. He's been given ceftriaxone. The swelling is spreading to his hands now. He's still in this condition. Had an allergic reaction to that, so had to give it up. Prescribed blood thinners, of course. Colchicine, interestingly. He's had extremely high ESR, C-reactive protein of very, very high levels as well. And his ferritin is very high as well, over 600. So thoracic ECG, nothing indicated. The cardiologist has recommended a follow-up ECG, yet to be scheduled. But overall, they're a little bit lost. And I'm just wondering whether you've ever seen a syndrome like this with these kinds of images here, which are indeed very worrying. I'll stop sharing now. I could give you a lot more details on the case, but perhaps you just have a few tips.
Well, he's obviously got an acute inflammatory arthritic reaction of those particular joints. And arthritis can be driven by so many factors. My biggest worry is that he's got an infectious arthritis. I'd be looking for some sort of, acute infection, which could be almost any microbe. But that'd be my immediate worry. It certainly could be an allergic arthritic condition. But he's got some sort of infectious driver in there, is my guess.
EBV has been detected, and also CMV, Armin mentioned that earlier, as an IgG. But of course, in England, they only do IgG and IgM, so they wouldn't find IgM anyway if it's chronic.
But you'd want to say limit some sort of bacterial infection. I just wonder if you've even got a septicemia, and I want to do blood cultures and maybe a joint aspiration to see if there's a micro can be detected. That would be my first and most immediate worry. If we're sure,
absolutely, and not viral, then.
If we're sure that it's not an infectious driver like bacteria, which can extend to a septicemia, then the immune system has got its wires crossed in some way. And this is either an allergic arthritis or it's an autoimmune arthritis driven by molecular mimicry. And a good old-fashioned remedy might just simply be to fast. As long as he's not, too underweight, simply to fast and maybe empty the gut with Epsom salts and really rest up and see if that just damps it all down, and then put in place all things anti-inflammatory. And the two very useful tools to damp down inflammation. One is cannabinoids, so CBD oil. Gradually increase the dose, and the other is low-dose naltrexone, which effectively stimulates the endogenous production of opiates. And we know that all cells in the body have receptors for opiates and receptors for cannabinoids. We know that we have an endogenous supply of those, and both have good anti-inflammatory actions. So in that situation, which is obviously very acute, that combination might be a very good combination to use.
Thank you. Kunal Garg, who we know from his brilliant presentation on Toxiplex, he's just mentioned in the chat, could it be a sandfly-induced infection or leishmaniasis?
Leishmaniasis, yeah, absolutely. That's certainly a possibility. But to call it functional neurological, oh no, that was the lady before, wasn't it?
Yeah, this one is simply question mark. They can't say more than pyrexia of unknown origin, which of course doesn't help at all, does it?
No, that just means the immune system is very busy. And we know you can get a fever from allergy, and that's why hay fever is called hay fever, because you can run a fever, and that's driven by allergy to grass pollen, obviously. So the immune system is obviously active there. We don't know why, and he needs to put in place all things to damp down the inflammation and try to identify the thing that's driving the allergen. If you can't face the thought of a fast, then a carnivore diet would be a very good alternative, because yet you can be allergic to meat, but it's unusual. So a carnivore diet with lots of bone broth, and then all things anti-inflammatory.
Thank you very much. Some people are asking, Armin, go ahead.
Gillian, maybe what we forgot is about the hands. They are swollen. It's a lymphatic problem. So this is a lymphotropic problem. So the lymphatic system cannot detox. And all of this water, it's a localized problem. It's not from the heart. So this is an infection. Maybe the sandfly could be but it's lymphotropic. Maybe a virus, which is lymphotropic. And you need more detox for sure, to detox of liver. You need maybe some lymphatic drainage, but I'm pretty sure they will do that, because if you have such a skin, this is not good for you, for yourself. You have here pain, and so you need to bring out the water, the lymphatic flow, bring it back again. There's water in it, so there's a reason.
True. Some people are asking, they're saying they didn't quite catch all of that. Just to repeat, if you joined a little late, this has all been recorded, and the recording will be up on the website under past webinars within the next few days. So please don't worry about that. And some people are asking, where can they get the co-infection checklist? And there's also a Lyme checklist and a post-COVID checklist. They're all up on the website as well. Maybe at the end, if we have time, we'll just show you exactly where. So otherwise, please write to info@aonm.org. That's, we're holding this. It's the people organizing this. You probably got the invitation from us, AONM.org. And on that website, you'll see the lists. So I wanted to just try, if I have time, to go through one more brief case. Do I have time for that? I'm just looking. I've not been looking at the time at all, and I can't see it on my Zoom. Are you okay, Leona?
Absolutely. No problem.
I mean, this is perhaps the most complex of all, and I apologize in advance. But this is a boy, young man really, of 35. He had a very severe case of chickenpox at 11 months of age. He kept having febrile convulsions, one of which lasted for 45 minutes. He was given too much intravenous Valium to stop the seizure, and that resulted in a respiratory arrest and hypoxia. He was resuscitated and recovered, but following that he developed epilepsy, left temporal lobe sclerosis. He's been on the anticonvulsant sodium valproate since then, until recently when his medication was changed to topiramate. He had post-ictal psychosis a few years ago, which is recurring, and was put on the antipsychotic olanzapine. He's put on 25 kilograms in weight as a result. He was tested for toxoplasma last year, as he has a cat, and the test showed that he's had toxoplasma in the past, but it's not active at present. The mother is just wondering where else to go, whether to do further testing, whether to retest toxoplasma. Armin, I know that you say with toxoplasma, the difficulty is we only have an IgG and an IgM there, and nothing further has been developed worldwide. So we can't really ever know whether it's positive. But how does that sound to you?
Yeah, with the seizures, always check for Bartonella. Okay. So Bartonella cat scratches, they get it. Huh? Okay, toxoplasma could be difficult to diagnose. It could be reactivated. We find some IgM now in the tests. Okay. But not many, but Bartonella is very, very common in the world. I think the seizures fit to that perfectly.
Thank you. Brilliant.
But before the days when we had anticonvulsant drugs, the treatment for epilepsy was a ketogenic diet. Now, if any of you have any doubt about that, there's a lovely film starring my favorite actress, Meryl Streep, and it's based on a true story of a young boy called Charlie who had very severe epilepsy. None of the drugs worked. And when she suggested to the pediatricians that he might be put on a ketogenic diet, this was dealt with as a form of child abuse. But anyway, the upshot is he went on to a ketogenic diet and his epilepsy cleared completely. Now, the other interesting feature that you mentioned is post-ictal psychosis. Now, there's some lovely work done by a Japanese researcher called Nishihara, who's particularly interested in the mitochondrial basis of disease. And what he points out is that if you have abnormal fermenting microbes in the upper gut, these microbes get into the brain, probably via the vagus nerve, where you have potential for those microbes to ferment neurotransmitters in the brain. And so they may be fermenting neurotransmitters from, noradrenaline and adrenaline and dopamine into LSD and amphetamine-like substances. And this is the basis of psychosis. Now, we know from work done by psychiatrists like Karl Pfeiffer and Abram Hoffer that you can cure psychosis with a ketogenic diet and supplements to improve mitochondrial function, in particular vitamin B3, fish oils, and other such. So, I would say, try your lad on a ketogenic diet. And again, we know these the psychotropic drugs like olanzapines, they switch on metabolic syndrome. They set the thermostat for weight very high, so they go on gain. There's a lovely new book out recently called Why We Eat by Andrew Jenkinson, who's a bariatric surgeon. And he asks the mechanism, how do these people who are morbidly obese, they're 20, 30, 40 stone in weight, happen? And the answer is their thermostat for weight, their set point for weight is set very high. So they constantly feel hungry. They constantly are craving food to try to get more energy, but it's all just being laid down as fat. And this is what do. They set the thermostat for weight very high, so these people put on weight. Now, the starting point to reduce that thermostat is don't do a calorie control diet. That's the worst possible thing you can do because the brain just sets the thermostat for weight even higher. The first thing is, again, to do a ketogenic diet. So fuel the body with fats and fibers. So the blood sugar is absolutely level. Now, a very, very useful tool that helps patients do this is continuous glucose monitoring. And now anybody can purchase one of those from Abbott. It's called Freestyle Libra. You can put it on yourself. It goes on the back of the arm there, and it gives you continuous blood sugar levels. And the key is we want to see those levels horizontal with just minimal wobbles. And as soon as it's minimally wobbling and you're not spiking insulin and you're not spiking adrenaline, so much else falls into place. So I would say do a ketogenic diet, maybe even a carnivore diet, aim to control, and that will have very positive effects for not just the epilepsy, but also the psychosis.
Oh, thank you so much. That's a mother who's been struggling for 35 years, so that will be wonderful advice. Thank you, all of you. Is it okay, even though we are already 5 minutes past the hour, Leona, is it okay if we just do a few of the questions? And because so many have come in, I do think we'll have to start the next session with some of these questions, which we promise you will save. So does Lyme disease show up as intermittent blood pooling and intensely white feet that sting throughout the body? Armin, that might be something for you. Can it show up as that?
Yeah, we have the problem always with the platelets and the coagulopathies in this. So it's pretty clear that all of these infections, not just Lyme disease, it's all infections doing that. So we have clotting. And maybe, Sarah, you could say something how we could do from your therapies against clotting. Because
absolutely. I mean, the point here is where you have inflammation in the body, you have sticky blood. Where you have sticky blood, you have inflammation. The two things go inextricably together. And so all interventions to reduce inflammation is going to reduce clotting and improve blood flow. And the single most important thing, dare I say again, is to cut out sugar. Sugar is pro-inflammatory, and it makes for sticky blood. It's sticky in the hand and it's sticky in the blood vessels, almost certainly because it destroys fourth phase water. But by contrast, ketones are markedly anti-inflammatory, and they reduce inflammation and they make for less sticky blood. And with an understanding of this and other interventions to improve fourth phase water, like vitamin D, vitamin C, all these interventions, then my view is that the need for anticoagulants will just melt away. And remember, anticoagulants cause problems in their own right. One of the biggest problems is you risk bleeds into the brain. Now, the brain is anesthetic. We have no sense of pain inside the brain. You can do brain surgery on people. Yes, you have to anesthetize the meninges, but once you're in the brain, no problem at all. And that means should you have a bleed into the brain, you would not be aware of that. And it always worries me that people who are on anticoagulants, they could fall over, they could bang their head, and they could be completely unaware that they're getting recurrent micro bleeds into the brain, which of course eventually destroys the brain and leads to dementia. So I don't like anticoagulants. I don't like warfarins. I don't like the other new anticoagulants that come onto the market. I don't like using aspirin for that very reason.
Yeah. Apixaban, for example. Yeah.
Exactly. Yeah.
One question that's come in is whether you would support lumbrokinase, also sometimes called Boluoke. That's a brand.
It's biologically plausible that things like serrapeptidase and lumbrokinase and the likes can break down aberrant, abnormal proteins in the bloodstream. And in fact, at the Better Way conference, I shared a stage with Paul Marrick, and we had a long chat after. He's a great advocate, of course, of high-dose vitamin C for infections. And he was saying that he was getting results using nattokinase and serrapeptidase in treating people who had spike proteinopathy. I mean, the problem with spike protein is it's markedly pro-inflammatory and it gives us very sticky blood. And guess what? We know that, don't we? After people have had their COVID jabs, they risk clotting episodes, myocarditis. This is well recognised. And he maintains that using things like lumbrokinase, these enzymes, helps to break down spike protein. He also points out that a very good way to deal with spike protein is intermittent fasting, because that switches on autophagy or autophagy, which means that the immune system itself will gobble up those spike proteins and render them inert. So intermittent fasting is going to be another very helpful tool, which again is gobbles up these aberrant proteins that we find in the blood, that are present in the bloodstream following COVID or infections. And again, it's a useful tool that anybody can do.
Super. Thank you very much.
I would add to this that the people drink too less water, and they drink also sugar in the water, the soft drinks as an example, and avoid all of the sugar in the drinks, not just in the food. Okay.
Absolutely.
And drink minimum 3 liters without gas every day. Otherwise, forget all of these therapies. Huh? You provoke the clotting. If you don't drink, you provoke it. Drink 4 liters. Drink. Start in the morning. Drink a good tea. In England, you have the best teas there. But drink, and no sugar in it, please.
The only thing to be mindful about that is whilst one can drink pure water, you cannot pee pure water. Urine always contains electrolytes, and not just sodium, magnesium, potassium, but zinc, copper, chromium, selenium, the whole shooting match. So in parallel with drinking more, you must take extra minerals in the form, and all those minerals in a physiological dose is going to be very helpful to help rehydrate the body.
And
Thank
no
you.
water and plastics. Please drink just water from glass. Okay, plastics, you get the microplastic problems in the gut, in your vessels. So we know that. So no plastics.
You are so right. And I think that plastics as pollutants are going to be as pernicious as pesticides and heavy metals. And the trouble is there are no biological enzyme systems that we know of that break down these plastics. So they are going to accumulate, and they're immunotoxic, and they physically get in the way and disrupt disrupt normal biochemistry. So I couldn't agree more with you, Armin. I think plastics are so pernicious.
And Sarah, no fish with plastics. The fish eat the plastics, and you eat the fish in the plastics.
The microplastics, yeah, that they've gathered from the
No,
ocean.
I know.
Yeah.
It's so sad.
Well, it's probably round about time for us to wrap up. What we will do is save all the questions. Quite a lot of them are sort of smaller questions that relate to how many drops of iodine to use in the salt pipe and things like that, where patients can get their methylene blue. What I think would be brilliant is if we advertise a little bit more overtly your individual talks, Sarah, which we are helping to organize, because you do regularly hold talks specifically on methylene blue, on iodine, on viruses and so on, from a UK perspective as well, where to access all these things. So we will do that in future. Every time Sarah is going to give I think that would be a lovely thing to do. We'll just make sure we send out a little e-blast and let people know that that's happening. And so don't worry, your questions will all be answered, and we will start the next roundtable, which we'll have early on in the new year, with these questions that are all here, both in the Q&A and in the chat. So I don't think I'd be able to elegantly enough show you exactly where the checklists are on the website. But again, we'll start the new year with showing you around the AONM website a little bit more, just so that everybody here familiarizes themselves with that. And of course, Armin, we can always send out the checklists, can't we, to people? If you just write into AONM, info@aonm.org, then we'll send them out to you. And we do have many of them. We even have checklists for parasites as well, which we don't have up on the and also specific checklists, for example, for colitis, for IBD type conditions. So just ask, and we'll, if we don't have a checklist, we'll try and devise one, won't we, Armin? So thank you so much, everybody. Thank you for spending your time with us. Again, close to Christmas, we know it's difficult and everybody's so busy, but thank you all very much as well, our panelists, for being there, for your fantastic answers to these very complex questions today. And look forward to having you all back again soon.
And thank you, Gillian, for organising this. I know it's a nightmare it is organising, but you do a brilliant job. So thank you too.
Thank
you guys.
Thank you.
Okay.
Bye.
Very happy Christmas.
Happy Christmas, everyone.
Cheerio ho. Bye.
Bye-bye.